Hello everyone, this is Miss Gerald, and in this PowerPoint I'm going to be talking about managing care, which includes prioritizing care and care coordination. Now I'm going to let you know that this PowerPoint will be a little lengthy because managing care, there are a lot of questions, NCLEX questions, that will be covering on managing care. You must know how to prioritize your workload. You need to have a system, and you need to understand what patients would I see first, what task would I do first, what can I anticipate care that's going to be happening for my patients. This information is really critical, so yes, I'm going to tell you in advance the PowerPoint will be lengthy. Please do not try to see it at one time with this PowerPoint. Take it, chunk it, and what I mean by chunking it is sit in about every 20 minutes, take notes, come back to it later. Take notes, come back to it later, okay? It's always going to be there available for you so you can listen to it over and over again to accompany the reading. This PowerPoint will not, again, it will not replace the reading in your book as well as reading the PowerPoint. So let's go ahead with that in mind. Let's get started. So your student learning outcomes. Here are several of the student learning outcomes, your objectives, what you need to make sure you are able to answer by the completion of this PowerPoint. You need to be able to define care coordination. You need to be able to understand the overview of prioritization. You have to describe the benefits. Why is it important for nurses to prioritize care? You need to be able to describe different methods. What methods are you going to use to identify what to prioritize? You need to be able to summarize factors to consider when prioritizing care. You really need to understand the delegation process because as registered nurses, you will have the responsibility of delegating tasks to the LPN or the UAP. LPN, the licensed practical nurse, or the UAP or nursing assistant. And you need to be able to discuss some pitfalls or prioritizations, and because of those pitfalls, what are some of the negative outcomes that can happen. Okay, I will tell you, in order to manage care, you have to know lab values. This was one of the things that you learned, and you got a lab sheet when you went through the patient safety hospital day at 111. There was a group of students, second-year students, that did a station that talked about labs and the importance of labs. So in order to manage care, you have to understand the normal lab values. Know your lab values on the BMP, okay? Your BMP, basic metabolic panel. This includes your potassium level, your sodium level, chloride, calcium level, bun, creatinine. Also, you need to, another one is magnesium. You need to understand your critical values for CBC, the complete blood count, your H&H, your WBCs, your RBCs. You need to understand what is a normal O2 sats, greater than or equal to 95%. You need to know these. You need to know normal vital signs. I'm not going to go and reteach those now. You have your resources. Dr. Meekin said that at the beginning of 111, you should have already have these normal lab values in your clinical notebook, okay? You need to review and remember the importance of an SBAR, hands-off communication, as a critical part of care coordination, okay? I'm not going to go back and reteach that. Ms. Locklear taught that, but you need to make sure you remember it and how now it is so important when you're talking about care coordination. All right, so care coordination, a working definition. The ANA, American Nurses Association, has a position statement that came out in June of 2012, and it gave us a definition of care coordination as it was defined by the AHRQ. Now remember, when I did the PowerPoint on quality improvement and health policy, I told you that these were one of the federal agency, the AHRQ, that you needed to be familiar with, as well as one of the benefits of the ANA. They put out position statements. Search the web on different position statements about the ANA, but one in particular that was put out was to define care coordination and how important it is for nurses to understand this concept. So their definition says care coordination is the deliberate organization of patient care activities between two or more participants, of course participants meaning the patients, involved in patient's care to facilitate the appropriate delivery of healthcare services. So basically, care coordination is a deliberate organization. You just don't come into work one day or even come to clinical and say, where do I start? How do I organize my day? How do I take care of patients? How do I manage the workload? How do I manage the interventions and the task? Care coordination is a deliberate organization, and we'll talk about that in this PowerPoint. How do I manage and take care of these patients and be safe? Okay? Care coordination promotes greater quality, safety, and efficiency in care, resulting in improved healthcare outcomes, and is consistent with nurses' holistic, patient-centered framework of care. This was all in the ANA's position statement. Okay, it is critical. You will see a lot of NCLEX questions on prioritization of care. Even when you watch the test-taking strategy, some of those examples and what they were talking about is how I prioritize care. How do I manage care? Who do I see first? What patient do I delegate? So you have to understand this concept. Okay? So really briefly, the next two slides talks about an overview of case management and how important it is to have a working knowledge of case management. I talked about case management in 111, so I only put in 2 slides here as a refresher. Case management involves a multidisciplinary team that assumes a collaborative responsibility for assessing the needs of the patients, planning and coordinating, implementing and evaluating care. So doesn't that sound like the nursing process? Assessing, planning, coordinating, implementing, and evaluating care. You need to be able to do this for a group of patients from admission to discharge, even pre-admission to post-discharge, because pre-admission means we are able to coordinate their care going to the doctor's office, community resources, pre-admission, and even post-discharge when the patient gets home, home help, again, community resources, follow-up doctor's appointments. Case management may not always be a nurse. You can have social workers that are case managers. Also, they can be referred to as discharge planners. Case management models focus on the needs of integrated delivery system. So what does that mean? Case management focus on the needs of not just one particular system, but the whole array of services that are involved or resources that are involved to make sure this patient's healthcare needs are met. Okay? Case management often used within the care management model. You're not going to have to know that model, but just know the main purpose of case management is that they really work as an interdisciplinary team to meet the needs of patients. Typically, the patients that are your more sicker, most critical patients, that's when care management is involved with these patients. We want to make sure that we can track the care for these patients, that we can prevent these patients from being readmitted into the hospital for the same disorder or disease process. We want to make sure that we are managing their disease. We want to make sure that we are ensuring that core measures are being met and that we are meeting the benchmark, okay, according to the Joint Commissions with those core measures on particular diseases. All right, so this first 2 slides is just truly an overview of care management. All right, so let's go right into prioritizing care. So the term priority just simply means you're making a judgment call here. you are having discernment on what task do I need to complete and why. Okay, which task needs to be done first or in a certain order according to a level of severity. So how do I prioritize? Okay, we're going to talk about that. Prioritizing care is a process that helps nurses manage time and establish an order. Remember, the ANA says in that position statement, it's a deliberate organization. So prioritizing care is a process that helps nurses manage time and establish an order for completing responsibilities and care interventions for just either a single patient, or now that you're going into 112, at least 2 patients. Okay? How do I set these priorities? What order? Do I just come into clinical and say, I don't even know where to start? Or do you have a plan that is a deliberate organization according to certain guidelines? Okay? Prioritizing care helps nurses to manage time. It establishes order for completing responsibilities and care, not only for one patient, but for a group of patients. You have to be able to critically think. What do I do first? How can I be in the middle of taking care of a patient and then an emergency comes up and I have to refocus? What do I do when I go into a patient's room and I assume that patient is alive and well, but I walk into that patient's room and everything is not alive and well? It's not going well for that patient. The patient may not have a pulse. The patient may not be breathing. What do I do? The patient may simply be in pain. The patient may have a blood pressure that needs to be addressed. But then I have another patient that's having problems breathing. Who do I see first? Optimize nurses' time and productivity by categorizing tasks in order to categorizing tasks in order based on significance and urgency. So I need to be able to critically think on how I'm going to have a deliberate order based on the significance of that patient's condition and based on the urgency level. And we'll talk about that. Time can be a factor and placed in this equation. Nurses, think about it. You're only going to have a limited amount of time to make a clinical judgment call and to perform necessary interventions. So what do I mean by that? When you get to work or you get to clinical and you have your 2 patients, you get vital signs, you have medications to administer, you have new doctor's orders that are constantly coming in. You have interventions that are already in place. You have to document in the electronic medical record. You need to respond to your patient's call lights in a timely manner. So there are multiple tasks that you're going to have to do. Multiple objectives will need to be completed during your shift. And you're thinking, wow, but I have 12 hours to get it completed. Trust me, sometimes 12 hours still isn't enough. So how do I do this? Time management helps nurses ensure that necessary activities are completed. You can't complete it all, but you have to complete the necessary activities within your shift. And you as the nurse have to prioritize and understand those necessary activities and then what activities can be delegated. Okay, now think about this. Unfortunately, some nurses just come into work and say, well, I have 4 patients that I'm assigned to today. I'm just going to see these patients. They're in room 1, 2, 3, and 5. I'm just going to see these patients in a geographical order in the way they're assigned. I'm going to start room number 1, see room number 2, room number 3, and room number 5 in that order. Not going by the patient's diagnosis, the patient's condition, what we get when we do bedside shift report and we do a bedside SBAR. Don't even take that into account. But some nurses, unfortunately, that's how they work their day, and they complete their items on their shift by a task list, and they do it in that order that's suitable for them. That is not the safe practice way, okay? Get out of that mindset, because you will not be able to not only provide safe care for your patients, but you will not be able to master those NCLEX style questions surrounding prioritizing care. Okay, so identifying what to prioritize. Qualities that affect patients' perception of nursing care. Effectiveness. Are we doing the right things when we are prioritizing care? Efficiency. Doing things right. See the difference here? Are we doing the right things? And in the things that we are doing them right? Are we inserting that IV the right way? If we see that IV is in place and we've started that IV, then are we assessing that IV as we should some facilities will say 4 hours. If you're in the regular floor typically is 4 hours. Are we doing that? And are we recognizing those complications? And are we intervening in a timely manner? Nurses employ effectiveness and efficiency by doing what? Setting priorities, managing time, and delegating to staff. Okay, it always starts with what? Assessment. Yes, assessment, the first step in your nurse's process. So again, with prioritizing care, managing of care, it starts with assessment. Helpful assessment data before you do anything. You need to look for cues. When I say cues, observe for cues about the pace of your unit, emotions of staff that are already working on your unit. That should be some cues. When I come into work, most of you already know that I still do bedside care. Sometimes when I come into work, I can just look at when I first come onto the floor and clock in, I look at how the nurses that are already there that are going off shift, their pace and how they're working. It's like it kind of sets a tone. I pick up on those cues. And I can say, oh my gosh, it's going to be a good day, or oh my gosh, do I need to turn around and go back home? But that's still part of my overall assessment, just of how the flow of the unit is going to work. After getting information from my bedside shift report, I make a quick safety check of our patients. So this is what you're going to be doing when you come into clinical and you get your assignment. You will go and do a quick bedside shift report utilizing an SBAR. And while you are in that patient's room, you will do a quick safety check of that patient. Is that patient have an adequate airway? Are they breathing? The ABCs. Okay, is suction set up in that room? Is the IV site working? Because God forbid your patient colds and you don't have a working IV site or suction set up in the room. Okay, are there any other tubes in place that the patient have that's working condition? For example, a chest tube, a wound vac. Is the Foley catheter in place and is draining well? A rectal tube, an NG tube. So it's a quick safety check that you need to do on that patient. That's part of your assessment. Become aware of any safety risk that's in place for your patient. If a patient is on oxygen, is that bed supine, or is the patient in a supine position, or is that patient in a semi-Fowler's position if they are on oxygen or at risk for decreased oxygenation or at risk for aspiration? What position is your patient in? Look at safety risks. Ask about the complexity of your patient problem when you're doing this bedside shift report, reviewing the SBAR. Okay? Know any routine responsibilities and interventions that have time constraints, meaning, is there a lab that have to be done at a certain time? Is there a certain medication that needs to be administered? Some IV medications have to be administered in a timely manner, or it affects the lab. Particularly when we give our vancomycin, it has to be given on time because we have to draw the vancomycin peak and trough. So if that vancomycin is not administered at the correct time, it can alter the labs, which in turn can alter the doctor's orders in managing and dosing that vancomycin for that patient. That's what you need to know when you're doing an assessment and a bedside shift report. Okay? Know how many and what level of nursing staff is available. Okay, so who do you have working with you for today? Do you have a nursing assistant? Is your floor have LPNs that's working on the floor? Because LPNs can do certain things that more tasks that the CNA cannot do, but then still an LPN is still limited on can't do quite as much as what the RN can do. Know your staff, who you have working for you, okay, or working with you for today. Ask about any patient preferences. You're talking about prioritizing care. If you have a patient that prefers to pray for the first hour of your shift because of their culture or their religious background, and if it's not going to compromise their safety, do you need to start with that patient first? No, you need to respect that patient's wishes, okay? So ask about any pertinent patient preferences. You must be able to assess and prioritize threats to airway, breathing, and circulation. There's your ABCs. I know we have said that and said that time and time again in 111. It has been said in the test taking strategies. And so there it is again. You must be able to assess the ABCs. When you are doing a bedside shift report, when you first come on doing that assessment, part of that quick safety assessment is ABCs. Okay, that's how we even first get started and initiate prioritizing our care assessment. All right, the nursing process. It is mandatory, folks. It's not an option. You understand the nursing process. It guides our care. It gives us a framework on how we determine priorities. The National Council of the State Board of Nursing provides models for states to use in revising the Nurse Practice Act and the Nursing Administration rules. The nursing process is mandatory. The nursing process helps us to make clinical judgment call, decision making, critical thinking in the nursing process. Maslow hierarchy of needs. This is not new. This is a review. We always first start with prioritizing care based on ABCs, first and foremost. Then we go to Maslow hierarchy of needs. Hierarchy of needs. And think about that. Look at the triangle here. At the bottom, physiological, safety, love and belonging, esteem, self-actualization. It's going to help you when you think about your nursing diagnosis, how to prioritize nursing diagnosis. It's based on ABCs and Maslow hierarchy of needs. Okay, if I have a ineffective breathing pattern or alteration in tissue perfusion, of course that's going to take priority over anxiety or low self-esteem. Okay, so think about that. Utilize, these are methods. These are methods that we're going to use to prioritize our care. Okay, the nursing process and Maslow hierarchy is a guide to help you to critically think about the order in which to address the patient needs. All right, so now we go into the low priority, medium priority, and high priority. And this is just an example of how we can prioritize our patients and how we're going to see them and how we're going to address that their care is met. When I think about low priority patients, can these problems be resolved with minimal interventions? Maybe the patient just needs to get ready to get their bed bath before they go for a procedure, or they simply just need vital signs and medications to be administered, just their regular routine medications. Problems that do not cause any significant dysfunction, they are placed into the low category. Okay, then the medium priority, non-life-threatening problems that may have unhealthy or emotional consequences. So we put emotional consequences in that medium priority, because if a patient is emotionally unbalanced, it could lead to suicidal ideation, which can then lead to safety issues. So we need to be aware of the patient emotional status. Okay, that's a medium priority. Not life-threatening, but it's in that medium priority. And then your high priority would be life-threatening conditions, any problems dealing with the ABCs, airway, breathing, and circulation. That's high priority. Patient high blood pressure medicines, heart medicines, patients on oxygen. I need to make sure I see these patients first. Patient has a tracheotomy in place. I need to make sure I see these patients first, okay? Conditions that may also have a potential to become life-threatening. So if I have a patient that's on oxygen at 3 liters, 2 to 3 liters, and they have a history of asthma, they're in for acute asthma, there could be a potential problem. I need to put that patient there in my high priority and get that patient seen, okay? Okay, categorizing priorities. The nurse must set priorities for nursing activities and interventions. And I just said that using the assessment data with consideration of low, medium, or high interventions. Think about time constraints that are in place, and that can play a factor. The next slide we're going to go into is going to talk about the urgency factor, and we're going to really spend more time there. Because we know there are different categories that can, or there are different concepts that can affect prioritization, but how do we as nurses overcome those? So we know time constraints. We know patients, there are some deadlines for completion of some interventions, and I gave that example earlier in the PowerPoint when I talked about scheduled medications, vancomycin, or scheduled antibiotics. Those antibiotics are administered every 12 hours, every day at a certain time, Q6 hours. That's a time constraint. I have to make sure I prioritize my care based around patients that are receiving those type of scheduled medications, as opposed to other patients that's not on those medications. I want to see those patients that's getting the medications with the antibiotics that are timed at specific time frames first. Okay? So think about that. Setting priorities include planning your day in advance. So as a nursing students, we do have you to come in the day before and do preclinical. But as a registered nurse, you don't come in the day before and do a pre-workup before you actually come to work. You come to work, you clock in, and you plan your day in advance in a very short amount of time frame. Some nurses come in about 15 minutes early. And really off the clock, just kind of come in and look through patients' records and see what they need to do to help them. On my unit, we are allowed to come in and we take about 10 to 15 minutes after we clock in, go through Epic, right? Just kind of look at medications, look at labs, look at scheduling, and then we're ready to do bedside shift report. But we plan our day in advance, okay? Essential activities not performed may result in negative consequences. If there are essential activities for patients and it's not done, and not only can it be a negative consequence for the patient, but it can be for you as well. It's in terms of you've been written up or having other disciplinary actions. So this is where I was talking about the urgency factor. Urgency means the need to act. Time priority. Time constraint is present when completing actions. So I know I need to understand the urgency level, the time that is involved, a time priority, and I need to understand the urgency factor. So we're going to go into this a little in detail. The urgency of interventions are affected by the patient's changing condition. That's why we always have to assess and what? Reassess, ongoing assessment, because patients' conditions change at any moment. We need to make sure that we are aware if our patient has any deterioration of their healthcare status. Is that blood pressure getting better? Is it getting lower? Is it getting higher after I've given this medicine? I have to reassess after I give medications. Ongoing assessment. Also, the complexity of your patient's condition plays a huge, huge factor in the urgency factor. The patient conditions. So we're going to talk about these on the next three, I think it's the next 3 slides. We're going to talk about it, the urgencies. Okay, so here is a table. I got this from your book, and it talks about the urgency levels. Okay, this just came straight from your book. Okay, is this intervention, is it non-acute level, which means it's on the lower urgency factor? If I didn't do this intervention, if I delayed this intervention, it would not impact the patient's outcome. It's not going to negatively affect this patient outcome. If I did not give this patient a bed bath today, that is not going to affect this patient's outcome. Okay, non-acute level. Then you have the acute level. It's a medium priority. So I kind of put that down there so you can see low, medium, high, in between that critical level, and then that imminent level that can result in death. So the acute level is your medium level. It's low potential to become life-threatening. It's your necessary interventions are scheduled and expected. I'm expected to pass medications such as vitamins, medications such as a stool softener, a medication. So you understand what I'm saying? I have a schedule to pass those medications, but they're typical. They're not going to become life-threatening, okay? Medium priority. Your next one is critical level. The urgency level that's critical. Okay, so think about this: potential to become life-threatening. Quick recognition and rapid response needed to stop the threat from becoming life-threatening. So these are where you see your patients where, okay, you came in at the beginning of your shift. The patient, they were doing well. They were not complaining of any chest pain, no shortness of breath. They were coherent. They didn't have any. They were not confused. They were not lethargic. Vital signs were good, to include adequate pulse ox level. And then maybe 6-7 hours through into your shift, the patient started having abnormal vital signs. They started getting more confused, but they were, and you wanted to go ahead and intervene at that point. That's when you can call rapid response. You can go ahead and notify the doctor to get some orders in place. But we want to do this to stop the threat from becoming life-threatening. We want to activate rapid response before it gets to a cold blue. That leads us into the next urgency level, which means imminent death. It's the highest urgency. Nurses take action takes priority over anything else. Nurses must act immediately to prevent further deterioration or to preserve that life. And this is truly in your code situations. You need to make sure everything you drop, or not even in your code situation, it can be life-threatening if a patient's blood sugar is 40 and they are symptomatic. That could be life-threatening. Or if the patient's blood sugar is significantly high, that could be life-threatening because they're getting ready to go into DKA, diabetic ketoacidosis. So we need to understand that, okay? Understand these levels, low, medium, high, the urgency levels, because what you will see, I will give you questions, and I will ask you, what patient do you see first? I will give you scenarios about a patient, and then I will ask you in the question, who do you see first? Then I will ask you, who do you see next? Then I can change up their condition and say, okay, now list the patients in order and how you would see them. Okay? It also will help you in clinical to understand this. So the ranking activities. Priority 1 is what you must do. It's the highest priority for completion. Now we're talking about tasks to complete. Don't get that confused with the urgency levels for setting priorities. This is the activities of how I'm going to rank the actual activities. Number 1 is a priority. I must do this. It takes priority over other interventions. It has to be done. And an example I can think of right off the top of my head with this is doctor comes in, patient has urinary retention. And the doctor comes in, assesses the patient, and writes an order to insert Foley catheter. Okay? You as a nurse sees that order, and you keep putting that order off and say, well, that's something that can be done later. I'll just hang on and let the next shift that comes on do that, insert that catheter. No, that you cannot do that. That is a must do on your shift. That's what you need to categorize as a must do. That's just an example I can come up with. But think about priority number 2, should do. So these activities should be done, but they're not essential. So they should be done, but they're not essential. They can be done once. As a must do, and then the activity is completed, or it's something that I can pass along to the next shift to make sure it gets done. One of the examples I can think of here is patient is scheduled for a certain procedure and it requires a consent form, but it's Friday. The procedure is not going to be done until Monday morning. The doctor writes the order on late Friday evening shift, late. So that's something that should be done, but it does not have to be done today. We can get the consent as long as that consent is done before the surgery, okay? And that's typically what will happen if I work over the weekend and the doctor writes an order that I know that procedure is scheduled for Monday, then I will make sure that we get that consent done and on that chart by Sunday day shift, okay? Should do, priority 2. And then you have priority 3, or simply nice to do. It's important to complete, but only after you have done your activities that rank priority 1 and 2. Then if time permits, you can do priority 3, or maybe this is something in a priority 3 category that you can delegate out. And we're going to talk about delegation process later on, okay? You need to understand that. Nurses, typically your nurses have to do priority 1. Some of priority 2s can be delegated out. A lot of the activities in priority 3 is something that can be delegated out. Okay, this is another table. It comes straight from your book. I think it's module 36 under prioritizing care. So it just came straight from your book, and it just talks about, it's like a prioritization grid or a diagram, a tree, if you would say. Factors to consider when setting priority. We know number 1 is safety. It takes the highest priority. And then just go down the list, okay? In the middle, it tells you where to begin. Begin with assessment, then ABCs, and then the nursing process, Maslow hierarchy of need, the urgency factor, okay? At the bottom of that list, at the bottom of that little table, it says common methods for ranking priorities. You may see some nurses say priority 1, 2, and 3, like what your book has laid out for you. You may see some nurses say low, medium, high priority. You may see some nurses call it as small task, medium task, big task, non-urgent, urgent, emergent, vital to do, important to do, nice to do, but just make sure you have a deliberate, organized method for prioritizing your care, okay? And we're going to talk about further on the right-hand side of that table. It talks about pitfalls. We'll go into that a little bit later on in the PowerPoint. Pitfalls to avoid when setting priorities. Triage. Really, the only thing I just want you guys to remember about triage, I'm not going to do a lot of testing questions on triage. You have seen or have heard of this concept, have probably seen this concept in action in the emergency department. You have done your clinicals in the ER. Hopefully you've had time to spend time with the triage nurse. But the triage is basically another way to identify how do I prioritize care. This term is used mainly, again, in the ER settings, urgent care or doctor's office care, and that's when you will see patients are assessed and then they're put in categories as emergent, urgent, or minor, and that's when patients are sent to the trauma unit, or they're sent to intermediate care, or they're sent just to the urgent care side of an ER. At Southeastern, at Cape Fear Valley, they have different zones: red zone, blue zone, yellow zone, green zone. And those zones, if you're in the red zone, that means it's emergent care. You're coming in, they are in the middle of chest compressions coming right off the ambulance. And then urgent, you may be in the blue, yellow zone. Minor will be in the green zone. So I'm not going to test you on that. That is truly FYI, just to be familiarized with that term, okay? Be familiarized with that term. You may see it again. Okay, I'm not really going to go back through this a lot on these next, I think it's 3 or 4 slides. It's just talking about, in general, other factors that need to be considered when prioritizing care. A lot of them we talked about already. We talked about time constraint. We talked about the condition of the patient's preference. But there's some other factors to consider as well. You need to make sure you're able to multitask. Even when you're prioritizing care in the clinical world, you're prioritizing and multitasking essentially at the same time. Multitasking is learning to perform actions faster, may improve effectiveness. Efficiency should never compromise patient safety, okay? It should never compromise patient safety, but you have to learn how to multitask. Some other factors to consider are the ethics. We need to understand ethics, safety, time management, availability of resources, multiple patients that we're taking care of. I talked about that in patient preferences. But ethics, we have to make sure when we are prioritizing care that we're also treating patients fair across the board. You remember that ethical principle, justice, being fair when it comes into place, okay? I'm prioritizing care, but I'm fair about it, okay? Difference among patients is urgency of needs. Life-threatening problems take priority over psychosocial problems, and we know that, okay? Life-threatening problems take priority over psychosocial problems. I'll say that again. Life-threatening problems takes priority over any psychosocial problems. Remember that when you're thinking about prioritizing your nursing diagnosis. Safety is a factor. We know we're not here to do harm to our patients, but only help them. Okay, time management, I'm not going back into that. Availability of resources. Again, looking at who you have on your team to help you. Nurse managers, LPNs, UAPs, who you can delegate to. Okay, so just have a working knowledge. Just kind of read through those different sections in your book that talks about factors to consider when prioritizing care, and that's on page 2536, and it goes to 2537. That will cover this slide. Okay, all right, let's move on. Changing patient condition. I just said that earlier. Patients need to be monitored continuously for changing circumstances. And guys, when you come in and do your initial assessment at the beginning of your shift, or when we are going to clinical and you assess your patient, Don't just say, well, I've assessed my patient, Ms. Gerald, and now I've entered my assessment into Epic, so I'm done with my assessment. Oh, no, no, no. Assessment is continuously done throughout your shift. We constantly monitor our patients and we reprioritize our care based on that, our assessment and monitoring of our patients, okay, for any changes, expected or unexpected. Infrequent assessment may result in inaccurate or incomplete data in our shift report. If I don't continuously assess my patient, then when it's time for me or you, because you will be doing this, you will be receiving BSI shift report when you come on, and you will be given BSI shift report when you leave. So if you have infrequent assessment, you could miss something, and you can't relate that information or communicate that information with your SBAR. That's critical. Nurses communicate with each other about problems and changes in patients' conditions, okay? That's SBAR. Expect the unexpected. Pop-ups can occur and will occur. Unexpected events that require your time and attention. It's going to happen. I remember I had one of my nursing instructors. I will never forget it. To this day, almost 22 years later, I remember her telling me, you always work your shift and take care of your patients as though you are going to be always ready for a code blue. And she would tell us that. She said, so what do I mean by that? She would tell us to always make sure that we are able to multitask, think about time management, prioritization, because when that patient codes, that's going to require a lot of your time and attention. And then it's going to take you away from your original plan for the day. So how do you get back on track and regroup and take care of those remaining patients? You have to be able to plan your day and be prepared for the unexpected. That's why I told you at the beginning of this PowerPoint, when you come in and you do BSI shift report, there are things that you need to be assessing and doing a safety sweep from the beginning in the event of a code blue, in the event of the unexpected. Does my patient have adequate ABCs, airway, breathing, circulation? Does my patient have an IV in place? Is suction set up in my room? Any other patient, is pain taken care of? So I can anticipate the unexpected and don't let that distract me from the care that I'm delivering. The unexpected can challenge time management and organization skills, even for the most experienced nurses. Guys, listen, even when I work and I take care of my patients and I come in, if I have something unexpected comes in, yes, it can alter my day or the way I'm managing my time, to kind of get me off kilter a little bit, but I do not let that overwhelm me, because I still know how to get back on point and say, okay, the code is over. We got the patient back, sustained the patient has been transferred to ICU. Now I can come back, regroup, refocus, and take care of the remaining of my patients, okay? And with a deliberate organization skills. All right, nurses self-care. You got to take care of yourself, guys. You have to take care of yourself. Short breaks need to be a priority. When we go to clinical, most of you already know, I do not tell students when to take their breaks, because you know where you are with your patient load. You know how you are prioritizing and you are managing your time. But you do need to take a break. I do not like the fact that students don't take breaks and they come and tell me, I don't have time, Ms. Gerald, to take a break. That is letting me know that you need to work on time management. You need to work on prioritizing your care when you come to me and say, I can't take a break. Short breaks need to be a part of your priority, okay? Quality time to re-energize, to refresh, to take care of yourself so you can be available to take care of your patients. Timeout break for you, okay? You don't want to look like that male nurse there on the lower right-hand corner of the slide. You may feel like that, but you don't want to look like that. Not for your patients and family and your co-workers. take care of yourself. All right, let's spend the next 10 minutes talking about delegation. The next couple of slides is going to talk about delegation and then the pitfalls of prioritization. So delegation, yes, you as the future registered nurse will be expected to delegate. You would delegate tasks to other nursing staff such as your LPN or LVN. You may see it both ways. LPN, licensed practical nurse, or LVN, licensed vocational nurse. You will be expected to delegate to UAPs or CNAs. They're the same. UAPs could be medical office assistants, unit secretaries, nursing assistants, but for testing purposes, with NCLEX World, you will see UAP, and it's synonymous for your nursing assistants. RNs need to be aware of their legal responsibilities in delegating, and there's a delegation tree. I think I included in here. We talk about delegations. If I didn't, I'll make sure you get a copy of the delegation tree. Okay? Very important. You need to know your task, and you need to know the task of the nurses, the LPNs and the UAPs, what they can do, what they can't do. Okay? Delegation requires trust and demonstrates trust in your staff members and in their abilities. So you need to make sure you trust who you're working with, okay, when you're delegating. The 5 rights of delegation. Do you have the right task, the right circumstance, the right person, the right direction and communication, and the right supervision? So the right task. Let's say if you have a task of inserting an IV. Is that the right task for an LPN, or is that the right task for a UAP? The right circumstance. Is there any circumstance where LPN cannot insert an IV? You need to understand that whenever you go to work for your facility. Some facilities say yes, some facilities say no. Is it the right person? Do I have the right person for the task and circumstance? Is it the right direction? Because as the registered nurse, you have to delegate the task, so you have to give the right direction on what you want them to do. You have to communicate clearly. Then you have to oversee and supervise that the task was completed. You can't delegate for a nursing assistant to insert a Foley catheter. You have to ensure that the Foley catheter is inserted and was inserted under the right sterile technique, okay, the right supervision. So you're probably saying, well, my gosh, if I got to do all of that, I might as well do it myself. You can't. No nurse is an island. You will burn yourself out. You have other priorities that you have to take care of. You must learn to delegate. Also, there are NCLEX questions that we're asking you how to delegate. They're delegation questions, okay? So you need to make sure you understand how to delegate. Delegating to the unlicensed assistive personnel, the UAP. I'm not going to read all of these, but please read these. The principles for delegating to the UAP. Nurses must always assess that patient first. That's number 1. You cannot delegate anything to a UAP or even to an LPN without assessing that patient for yourself as the registered nurse first. That patient has got to be safe. If a patient needs to be ambulated after a surgery and you have not assessed that patient first, you cannot tell the UAP, go and get that patient out of bed and to the chair without first assessing that patient's condition. Okay? Read through those and understand them, okay? You will see them again, not only for my quiz and test purposes, but for NCLEX. And you will be able to do this in the actual clinical setting. Principles for delegating to the UAP. So the delegation process. Steps, these are the steps to be followed in every situation. I just said assessment. You have to assess your patient and you got to plan for the intervention. Communicate, effective communication. Surveillance and supervise. I need to make sure that the person who I'm delegating to have already demonstrated competency that they're able to complete that task For example, if I'm delegating, again, maybe a Foley catheter or a simple wound care to the UAP, have they already been checked off and I know they have demonstrated competency? It's in their file that they can do these tasks correctly and safely. Then I need to evaluate. I need to go in and make sure the wound care is done, it's dated, it's timed. I need to make sure it's documented. Oh, excuse me, not documented. We'll talk about that. But I need to make sure that the Foley catheter, another example, was inserted correctly. So I need to go back and evaluate and provide feedback to the person that you delegated that task to. Okay? Steps to be followed for every situation in delegation. Always start with assessment, planning, communicate, supervise, and evaluate. This is basically just saying, excuse me, it's not saying the same thing. It is saying things that should not be delegated. The only thing I really want you to be aware of here is that, of course, we do not delegate any high technical tasks to the UAP. And your facility that you work in will give you that list. You can go to the North Carolina Board of Nursing. It will give you a list of what you cannot delegate to the UAP. We do have that listing at Cape Fear Valley, and I think it's there on the info web, and it tells items that cannot be delegated to the UAP, as I'm sure there is with other hospitals as well. If there's any situation that you are sure of, you always follow your chain of command. Tasks that may be delegated, and here are a list of them, and it may be more, so you always follow your procedure policies. Okay, but here are a list of them. This just came straight from your book. And I noticed that there are some that are not here that says like simple wound care. Usually those can be delegated. So again, just go by where you work for clinical purposes. But for testing purposes, I would truly go by what's listed in your book. Okay. And then tasks that may not be delegated to the UAP. We never delegate an assessment. Okay, never delegate any data that needs to be interpreted. If the UAP comes to you and give you vital signs, you should never have them to interpret those vital signs if they're low or high. That's the nurse's responsibility. Okay, they're only going to give you the vitals or enter the vitals in Epic. They're not going to tell you if it's low or high, because then they are interpreting the data. That is for you, the registered nurse, to do. You will never have a UAP to create a care plan. Not only the UAP, but hear me on this. You will never have the LPN to create a nursing care plan. Not only, I should have titled this slide UAP/LPN, because tasks that cannot be delegated to the UAP or the LPN is assessment and also creating that nursing care plan. The LPN can be involved in carrying out the care plan once it has been created by the registered nurse, but the LPN cannot create it. Okay? Evaluating if the care plan is effective. Only the RN can do that. Care of invasive lines, your central lines, your chest tubes. Only the RN can do that. Performing triage, giving telephone or I think they're calling it telehealth now. Only the RN can do that. Patient education. Hear me well on this one. The RN is the only one that can teach the patient. Okay? The UAP can never teach the patient. It is unacceptable if you see a nurse give a UAP a patient's discharge paperwork and say, here, go and give this to the patient. And it's their patient education. At no time. I have seen this, and it's so wrong. You cannot do that. Only the registered nurse can educate the patient. The LPN can reinforce education, but they cannot initiate education for that patient. We'll talk more about this in class. They can only reinforce education. The LPN can, but cannot initiate education. Okay, so if you have a patient that needs educating on Then send a spirometer. The nurse needs to initiate that education. Then the UAP or the LPN can ensure that the patient is utilizing the IES only after the nurse have provided the correct education. Okay? Please read that in your book and understand that. Very critical. No, I did include this. This is your delegation tree. I could not remember if I had put this in this slide. So it just tells you, you just follow the tree. First question, are there laws and rules in place that support delegation? Yes. Then you go right down the list. Is the task within the scope of the delegated nurse? Yes. But let's say if the first thing says, are there laws and rules in place that support the delegation? And the answer is no, then you do not delegate. Are there laws and rules in place that support you delegating patient education? No. Stop right there. Do not delegate. So this is a delegation tree that can help you in deciding when to delegate and or who you delegate to, going by the 5 rights of delegation. Okay, pitfalls of prioritization. Nurses may not know all of the pitfalls, but just know you can recognize some of them, and some of them you really need to avoid. The ones that you can recognize, you need to avoid, okay? Some that can be recognized is and should be avoided, excuse me, following ethical practices, using available resources, know patient's health concerns, have a sense about the patient's priority, prioritize care appropriately, use questions from clinical decision-making models such as your Maslow hierarchy of need, your nurse's process, okay? So if you recognize, these concepts that I just read out to you, then the pitfalls of prioritization can be avoided. That's what I was trying to say. If you recognize these that I have listed for you here, these items that I have listed, then you can avoid the pitfalls and you can correctly prioritize if you do those things, following ethical practice and so on and so forth. Other things that can cause you to have a pitfalls of prioritization, if you try to prioritize without assessment. You cannot do that. If you do, you're going to fall in the pit. An incomplete assessment, you're going to fall in the pit. If you don't have ongoing assessment, you're going to fall in the pit. Solely relying on another nurse's assessment. I know I have told time and time again to students who were in my clinical, you do not rely solely on another nurse's assessment. If a nurse tells you the patient had clear lung sounds, you don't rely on that data. You assess that patient for yourself. Those patients' lungs can change at any moment, okay? Failing to do ongoing reassessment, that you're going to fall in the pit. Poor time management, you're going to fall in the pit. Another one, not involving the patient in your care. We need to make sure that that patient is in the center of it all. What is the patient's preferences? If it's not going to compromise their safety, you're going to fall in the pit if you do not involve that patient in their care. Okay? Inappropriate delegation, you will fall in the pit. If you don't understand the appropriate task to delegate to the LPN and the UAP, you're going to fall in the pit. You have to understand that. Go by that delegation tree. Understand that delegation process. Doing the easiest task first. Hear me, this is the last slide. Doing the easiest task first. That's a pitfall. You do not do the easiest task first. Let's say if you have a patient and this patient have 3 bed sores, pressure ulcers. 2 of them are stage 3 and 1 of them is a stage 4. Then you have to put in a Foley catheter, and then you need to do a simple wound care, and then you need to do some patient education. Well, you probably want to go ahead and do your patient education first because that's simple and easy. That's not what you need to do. You need to start with the hardest, the most complex task first. Do not do the easiest task first. You're going to see this again on test questions. You need to be able to understand this for NCLEX questions, and you need to be able to understand this for clinical. If you try to do those easiest tasks first, you're going to fall into the pit. Go ahead and tackle your most complex first, because guess what? Those complex tasks are falling into the medium or high category and the high priority, I promise you. They're not low priority. So why do you want to start there first? Okay? You don't want to do the low priorities first. You want to start those medium and highs, which are typically your more complex interventions. Okay? I know this was a lengthy PowerPoint. You need to really take your time, listen to it again multiple times, take notes, read. There's assigned reading. There is a class activity on managing care. It is on LMS. We will do it in class. There is a quiz on managing care that you will complete before coming to class, because I want to make sure it is essential that you understand prioritizing care, coordination of care. Okay, if you have any questions or concerns, please do not hesitate to email me. Thank you.